Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me for this talk on cognitive dulling. Ever feel like your brain is in a fog, but you can't figure out why? The answer might be in your medicine cabinet. For millions, it's a hidden source of memory loss and cognitive dysfunction. You're taking medication to feel better, but instead you just feel foggy. Don't let medication steal your sharpness. This is what you need to know. In this presentation, I'm going to review the usual suspects, medications commonly implicated in cognitive deficits, and the mechanisms of action by which they rob us of our intellectual acumen. This is actually part 2, the second video in a 2-part series on medication-induced cognitive dulling. In the first video, I review the concept of cognitive dulling, how medications can actually induce a reversible, that is, temporary, dementia. Beyond the risk of delirium, which is more of a waxing and waning disorientation, and the other effects of intoxication like slurred speech, dysarthria, muscular incoordination called ataxia, droopy eyelids or ptosis, etc. Beyond these, there can actually be varying degrees of dementia, a loss of mentation, dementia, not unlike Alzheimer's or the dementia due to Parkinson's disease, with potentially significant short-term memory deficits, for example, or actual lapses, amnesia for discrete periods of time, or perhaps word-finding difficulty, or the inability to concentrate, the inability to multitask, trouble planning, deciding, judging, etc., only reversible. When the effects of the medicine wears off, the dementia symptoms revert. But if you're taking the medicine every day, importantly, most of these compounds result in sedation. And obviously, if you're on the spectrum toward unconsciousness, there will be diminished mentation. You can't think clearly when you're half asleep, given. So that's part of the story. But in directly interfering with neuronal activity, these medications act in more specific ways beyond just shutting things down a little, or a lot, globally. I'll talk more about sedation and GABA, gamma-aminobutyric acid, the major inhibitory neurotransmitter in the central nervous system. But just keep in mind that the following medications that happen to be sedatives have other ways of disrupting the intellect. For example, cannabis is a substance with increasing acceptance as a medication for certain patient populations, and marijuana can make you sleepy, sure, but it also frequently causes often severe but wholly transient short-term memory problems. I talk about that in video 1 in some detail. It has to do with THC binding to endocannabinoid receptors in the hippocampus, not sedation. The cognitive deficits in a person intoxicated with marijuana, if they took a very large non-medicinal dose, can be quite stark. Cognitive dulling, on the other hand, is more subtle. So subtle, in fact, that patients may be largely unaware of their difficulties, or if they do notice, they have no idea that it's the medicine that's causing it. The pills they're taking are the last things they suspect. When cognitive dulling is obvious, patients are prone to misattribute those symptoms, not realizing they're actually side effects. For example, a patient might complain of trouble focusing or sustaining attention, which they then might misattribute to ADD, attention deficit disorder. ADD is a fad diagnosis, meaning that most patients I come across who think they might have it do not, in fact, meet diagnostic criteria, in my opinion. But it's so famous and so much a part of popular culture, at least in the United States, that it's almost unavoidable in any discussion with a doctor regarding cognitive deficits that involve prominent distractibility, inattention, or poor concentration. But ADD is largely genetic. It's lifelong. It really tends to become apparent in early life, with or without hyperactivity. ADD doesn't manifest suddenly or midlife. Other complaints might include difficulty finding words, the tip of the tongue phenomenon, lethologica, a temporary glitch in word recall, on a spectrum with actual aphasia called Broca's aphasia, difficulty or inability to produce language. It's a symptom that's usually the consequence of conditions that affect language abilities more broadly, usually due to brain injury, especially following a stroke. The tip of the tongue thing is not aphasia. It happens to all of us infrequently. But when it starts happening all the time, that's a sign of cognitive dulling. I notice it with my Spanish. I'm a native Spanish speaker and hablo con fluidez, but the inability to retrieve a Spanish word happens much more often, even without medication. Even the ability to produce certain words, to actually pronounce them correctly in Spanish, especially with those that I'm not well rehearsed in producing, can be affected. which is called dysarthria, the inability to articulate properly. We're all familiar with slurred speech, but poor diction, enunciation, is not always a consequence of frank intoxication. It can be more subtle. And while dysarthria is not the same thing as stammering and stuttering, called dysrhythmia, cognitive dulling due to a medication or anything can cause both, one alongside the other. In my own case, for example, high-dose Lyrica exacerbates my baseline vulnerability of having trouble retrieving and pronouncing words in Spanish, but only in Spanish, because only my Spanish is vulnerable to that deficit. Or rather, my Spanish is more vulnerable. The threshold is lower. In other words, it would take flat-out intoxication for my English to deteriorate like that. I discussed this in detail in video 1. Be sure to check it out. With enough medicine, I also lose the ability to trill my R's, but that's a slightly different neurologic deficit. Likewise related, though, to the fact that I'm much more adept at producing English words and sounds and phonemes. I've noticed a much milder version of lethallogica with serotonergic agents, medications like SSRIs that increase the neurotransmitter serotonin, because serotonin is not conducive to volubility, talkativeness. Serotonin actually can lead a person to be reticent. It generally opposes dopamine. Dopamine, which on the other hand, can make one downright garrulous. Dopamine increases loquacity, and not just the amount of speech produced, but often its speed and accuracy, the velocity of all those ideas. More ideas, and they're faster and better articulated. A person who's angry because of too much dopamine can be quite vicious with their tongue or their pen. Too much, and we get pressured speech and flight of ideas, manic symptoms, especially if norepinephrine is also increased, noradrenaline. Cannabis does this as well for a lot of users, not the anger, but it induces logorrhea, word flow, also called diarrhea of the mouth, often coupled with problems remembering what one is saying, which can be a quite comical effect. But word-finding difficulty as a side effect? How often do patients complain of that? Almost never. They either fail to notice, or else they fail to put 2 and 2 together and realize it's the medicine. Another clue for the clinician is trouble with time spans. Time span estimation, keeping track of time, I'm talking days to weeks to months, is one of the most sensitive screening tools because it's one of the first abilities to go when a patient experiences clinically significant cognitive dysfunction, whatever the cause. Patients who are deeply depressed, for example, often can't tell you how long ago something happened or how long something's been going on. The days meld one into the other, but the brain just stops keeping track of that, which is an automatic function. We don't consciously think, this is happening and I'm going to keep track, and in 2 weeks I'm going to be able to say it happened 2 weeks ago. No, it's just an automatic thing that the brain does. But when there's cognitive dulling, due to severe depression, for example, and it's not there, the patients won't be able to answer those questions. It's the same for older individuals who are showing the very first signs of Alzheimer's. Ask them how long they've been having symptoms or when things got started, and they'll struggle to give even the wrong answer. They may simply draw a blank. They're not even able to guess in some instances. If the cognitive dysfunction is severe, the task of generating an estimate is too difficult. The task itself, never mind that they don't know, they can't even venture a guess. And then when you ask them to just give you an answer and they tell you something because you're just asking them to flat out guess, the family member will just shake their head in the background. And so when I see this problem, then I know to screen for other cognitive deficits and really do a comprehensive assessment of cognition, which it might not occur to us to do a lot of times when cognitive symptoms are not obvious to the patient or the family, and they're not a focus of treatment up to that point. Trouble judging and reporting time spans is the first clue. When I'm interviewing a patient and I discern that they've lost the ability to do that, then my next task is to figure out why, and is it reversible? But as far as most cases of cognitive dysfunction that are due to medication, I think patients simply don't know. Patients don't even know that they're losing IQ points. They rarely complain of these things when clinicians specifically ask about side effects. I rarely have had a patient complain of slowed thinking, slowed processing, strenuous decision-making, inattention, short-term memory lapses, or forgetting why they entered a room, losing things, etc. in response to my asking about any side effects. There is the occasional patient that will complain of feeling foggy when I ask, but most patients do not think about what's going on cognitively. They'll notice and complain of these things when they're significant, but not when I ask if they're experiencing side effects, even when those cognitive symptoms are new and sudden and we just started a medication. It's interesting, a lot of times when patients deny side effects and then I ask specifically about dry mouth or waking up in the middle of the night, patients will readily endorse those side effects. Oh, yeah, that's happening. Yes, I'm having that. Okay, anything else? Any other side effects? No. Okay, well, what about this? Oh, yeah, that too, right? So if they overlook those common, widely recognized symptoms, either they don't know their side effects or else they don't think to complain about them even when directly asked, imagine their inability to discern more esoteric, subtle cognitive loss as a temporary consequence of taking a new medication, especially when the side effect is insidious. It's not present at first. It comes on slowly as the dosage is titrated, as is often the case. Because cognitive symptoms due to medication are often dose-dependent, there's a threshold below which the side effect is absent, and then as we increase the dose, the severity worsens in parallel. The cognitive dulling doesn't present right away. It's gradual, insidious, and patients don't know it's the medicine when it becomes apparent. But it's important because even if a patient doesn't complain about it or is largely unaware of it, this cognitive loss can still affect occupational, academic, and even social performance. The quality of life can nonetheless be compromised. So I gave an overview in part 1, please be sure to check it out, but let's talk about the usual suspects here. Medications commonly implicated and the mechanisms of action by which they rob us of our intellect. Many psychotropics, certainly, medications that alter our mood and our mind, which include nootropic agents, substances that actually enhance memory, attention, learning, and even motivation to get things done and to learn and to achieve, which is critical to learning, by the way. Dopaminergic medications that increase dopamine, ADD meds, for example, which do that in everybody who takes them, not just individuals who actually suffer from ADD. But many other psychiatric meds can be detrimental. Antidepressants, for example, SSRIs. Serotonin tends to dull cognition. Dopamine is opposed. In my experience, the effect of blocking the reuptake of serotonin on cognition is relatively mild, though, compared to, say, the tricyclic agents, the TCAs, the first-generation antidepressants, which, in addition to this action, which might also be partially offset by a concomitant increase in norepinephrine with all of these agents, they're basically SNRIs, are also very anticholinergic, especially amitriptyline and doxepin. They block the actions of acetylcholine, which is vital in the hippocampus for establishing short-term memories. The release of acetylcholine in the hippocampus is important in encoding new information during periods of active learning and heightened attention. It does this in part by inducing theta oscillations and strengthening synaptic connections between neurons, increasing the likelihood that new information will be stored. The synapse is the gap between neurons where communication takes place. In my experience, blocking acetylcholine is more detrimental to cognition than increasing serotonin. Some populations are more vulnerable than others, but if both are going on, that's obviously twice as concerning, or more than twice. The combined effects are often not just additive, but synergistic, greater than the sum of influences. A double whammy situation becomes an exponential situation clinically. Then there are antipsychotic medications, 3 generations of mood stabilizers and antipsychotics, which treat a variety of symptoms, including mania, delusions, including both types of paranoia, persecutory and grandiose, hallucinations, nonspecific agitation, aggression, etc., but which are also often used as augmentation strategies for patients with major depression, unipolar depression, and in various childhood syndromes, such as the FDA-approved use of Risperdal for treating irritability in children with autism spectrum disorders. Antipsychotics is a misleading term because most people taking them are likely not actually out of touch with reality. It's better to understand their mechanism of action, so I like to refer to these medications as dopamine antagonists or partial dopamine agonists, and I have videos on all of this. Most of these agents cause significant sedation, which dulls everything, but apart from sedation, these medications can disrupt normal cognitive functioning, specifically through blocking dopamine. The mood stabilizer Lithium, used in bipolar disorder, but also as an augmentation strategy in treatment-resistant major depression, has been associated with mental sluggishness and in particular problems with verbal learning and memory retrieval. There are even some studies that suggest that long-term use may, in some cases, result in cortical atrophy, a shrinking of the actual volume of the cerebral cortices. How exactly lithium interferes with cognition in some patients, not all, is unknown. Just like we don't fully understand how it helps to subside mania. But it is almost certainly dose dependent. And again, it's important to distinguish between that and delirium, which can happen quite easily with patients. Lithium has a very narrow therapeutic index. Depakote, valproate or valproic acid, is another popular mood stabilizer. I myself have prescribed it thousands of times over the years, and never once did a patient complain of cognitive dulling, although some of them must have been experiencing it. Studies have shown an association between Depakote and bradykapnia, what I've been talking about this whole time, slowed thinking and processing. Brady means abnormally slow. There can also be memory problems, especially working memory, that immediate short-term memory that's always the most precarious. Depakote increases GABA activity, which leads to sedation, a general suppression of neuronal activity globally, and a general dimming and slowing due to slightly losing consciousness. All sedating medications have this risk in common, and GABA is the final common pathway. And like lithium, valproate therapy has been associated with reversible cerebral atrophy. There's even a rare but named syndrome, VIRCD, valproate-induced reversible cognitive decline. Note the word reversible. In these cases, cognitive function gradually improved after the medication was discontinued. Anxiolytics, for example, benzodiazepines. Here again, highly GABAergic medications that lead to sedation, sleep, and coma in the extreme, with a parallel loss of mentation along this spectrum of obtundation. Short-term memory in particular can be thwarted, with anterograde amnesia resulting. That's amnesia for events that occurred anterograde to ingestion, after ingestion, as opposed to retrograde. So short-term memory is intact for events leading up to dosing. But with sufficient dosing, a person can black out for what comes next. They're awake and active, doing and saying things, interacting with others, making decisions, but they won't remember it later. Scary, especially since good judgment is likewise impaired. Disinhibition of the frontal lobe causes more problems than whatever's going on in the hippocampus with short-term memory. Anti-epileptics, medications that dampen neuronal activity in the CNS in order to raise the seizure threshold to thereby decrease the likelihood of a grand mal seizure or other more esoteric seizure types, also frequently diminish cognitive capacity. Topiramate, or Topamax, blocks voltage-gated sodium channels. If you want a deep dive into this mechanism of action, please check out my trileptal and lamictal videos. This leads to a reduction in neuronal conductivity, the firing of neurons. But Topamax also enhances the effects of GABA by interacting with the GABA-A receptor, like benzodiazepines and barbiturates and Ambien and Lunesta do, and also blocks the effect of glutamate, the main excitatory neurotransmitter in the CNS, by antagonizing those receptors. With Topamax, it's important to distinguish cognitive dulling from actual delirium, most commonly due to metabolic acidosis, which is a risk due to topiramate's ability to inhibit the enzyme carbonic anhydrase. You providers in training out there, take note. Again, delirium involves a fluctuating sensorium, a disorientation that can include perceptual disturbances like hallucinations and can be conceptualized as a state of extreme intoxication when it's due to a substance. Other anti-epileptic drugs have similar effects. Zonisamide, Zonegran, which inhibits both sodium and calcium channels and also serves to stabilize neuronal membranes, reducing the excitability of those nerve cells. And levocetirizine, Keppra. Kepra's mechanism of action is highly esoteric. It binds to a specific synaptic vesicle protein, for those of you familiar with neuronal conductivity. But the end result is that it too regulates the release of neurotransmitters, which helps stabilize excessive electrical activity in the brain that causes seizures. And it too can cause sedation and cognitive dulling independent of that sedation. We also include the gabapentinoids, Lyrica, pregabalin, which I mentioned before in my own case, and Neurontin, gabapentin, in the list of usual suspects. Lyrica for me, definitely. If it affects my Spanish, I assume it must be affecting me otherwise, that I may just not be noticing. Anticholinergics. As previously stated, acetylcholine is important to cognition. Blocking acetylcholine is not advantageous to thought, and these receptors are widespread throughout the body. Many medications and substances block them, including the tricyclics and Paxil among the SSRIs modestly, but also antihistamines, many of which are available over the counter. Mirtazapine, Remeron, is an antidepressant with very weak anticholinergic properties, and so it's considered a good choice for individuals who poorly tolerate those particular side effects, such as the elderly. Besides impaired short-term memory, blocking acetylcholine receptors causes constipation, blurred near vision, and urinary retention, 3 conditions which many elderly individuals already suffer to some degree. Muscle relaxants like cyclobenzaprine, Flexeril, and to a lesser extent crisaprotol, Soma, also have these effects. There are thousands of approved medications with some level of anticholinergic activity, with studies listing hundreds and hundreds across various classes, and one study in particular easily demonstrating over 600 drugs. So particularly if a person is taking more than one medication, the chances of anticholinergic effects among them grows higher and higher and more certain with each added new medicine. And the older one gets, the more vulnerable to anticholinergic side effects one gets, the more medications get piled on. Don't miss my video on the evils of polypharmacy. Opioids can cause cognitive impairment, affecting memory, attention, and executive functions like planning and decision-making. If you take too much, you can end up delirious or obtunded, in a stupor or unconscious, and they depress respiration as well. It's potentially deadly, but at therapeutic doses, what's often described as a mental fog is not uncommon. Moreover, some studies show a detrimental effect over the long term due to chronic administration, even possibly increasing the risk of dementia in later life. Those studies remain to be replicated, but there is a suggestion of that. Beta blockers, corticosteroids, chemotherapy agents, Chemo Brain via inflammatory pathways are all possible offenders. The take-home message with regard to mechanisms of cognitive dulling has to do with neurotransmitter disruption, especially serotonin, GABA, dopamine, acetylcholine, and histamine. Dose-response relationships, noting the difference between sedation and direct cognitive effects. Sedation is not equivalent to cognitive dulling, but they often co-occur, they often overlap. Or you can see cognitive slowing without sedation, for example with topiramate. And also taking into consideration the cumulative burden, sometimes called the daily pill burden, polypharmacy, and additive or synergistic effects. And then there are indirect mechanisms, poor sleep, metabolic stress, even inflammation, all of which may contribute to the dulling effect. So the medication might interfere with sleep architecture, leading to poor sleep, and that exacerbates the independent cognitive dulling effect that's happening over here, and you get a synergism. A synergism within the same medicine. What can we do? What are some solutions? Well, certainly dose adjustments, remember the dose-dependent relationship, or drug substitution if that's a viable option. But if the risk-benefit analysis no longer supports taking the medicine, deprescribing is indicated, which is a consideration often overlooked by clinicians, especially when it comes to discontinuing medications other clinicians initially prescribed, even when they themselves have continued the medication. Upon admission to the hospital, for example, clinicians don't take ownership of those medications, even though they're refilling them because they were originally prescribed by someone else. This happens a lot too when an elderly person gets a new primary care provider, and maybe it's their third or fourth primary care provider for various reasons through the years. The elderly are more likely to have seen different primary care providers, and maybe they're seen by a nurse practitioner once, and then they're seen by the actual doctor the other time. So it's lots of different, too many cooks. And so they have this laundry list of medications, a lot of them as needed medications, but the patient is taking them on a scheduled basis because they misunderstand. So they're taking all this stuff they don't need, and each clinician in series just continues everything. They take a look, and as long as there's no dangerous drug-drug interactions or anything that just is glaring, then they continue everything. And they don't even think, well, maybe the patient doesn't need this medicine anymore. Maybe the good doctors do, but most doctors, I would be willing to say most doctors don't. because we have this pervasive problem of polypharmacy in the elderly. And I think it has to do a lot with not taking full ownership, just subconsciously, of medications that they are nonetheless prescribing. There's a hesitation to discontinue medication. Deprescribing is not a strategy that is at the forefront of a lot of clinicians' minds. They're there to prescribe, to treat, not to not treat. There are, of course, non-pharmacologic strategies. In addition, attending to sleep hygiene, getting more exercise, cognitive rehab. A higher index of suspicion is essential. Know which populations are most at risk. You providers out there, use the lowest effective dose, avoid polypharmacy, and remember, cognitive dulling due to medication is reversible in most cases with appropriate early intervention. Thank you. As always, comments and questions are welcome. Please stay tuned for more great content. And please check out my online academy, notonanemptymind.thinkific.com, for my premium content.